how many days would you wait to see if a patient has a response? Is there a guideline? I'm sorry?
We'd usually watch for an initial response, 5 to 7 days.
Okay. And after those number of days, if the patient has a partial response but still needs to complete the treatment course, would the patient B or C or both be shifted to other sites of care to complete the treatment or kept inpatient?
And you said they have responded initially?
Yeah.
If they have clinically responded, which for us very specifically means normalization in liver function test, less than 500 cc's of diarrhea, or a downgrading of skin GVHD. If they've clinically responded, then they could be discharged to home with close outpatient follow-up.
Okay. And okay, so is that actually? I'll get there in a second. So after those same number of days, if the patient has a complete response but still needs to complete the Product X treatment course, would they complete it inpatient, or would they be transitioned in that situation?
If they have responded but have not completed the course of 12 treatments?
Correct.
They could potentially go to our outpatient infusion clinic to complete the course.
Okay. And after these two patients are discharged, do they follow the same protocol as they would post discharge after their transplants? Is there any difference in the frequency of visits? Are they required to stay locally temporarily again?
Yes. Anyone with grade 3 or grade 4 GVHD will be back to that 3 times a week minimum number of visits, as well as would need to be within 30 minutes at the transplant center until, completion of GVHD treatment and, resolution or near resolution of symptoms.
Okay. Great. And compared to the situation with patient A, would the criteria governing patient B's and C's discharge be different the second time around? Would there be any different barriers facing you or the patient?
No. Yeah, I mean, a patient who has just moved home several hours away would have difficulty probably retransitioning back to our center's area.
Mm-hmm. Can that be
finding accommodation, I guess, would be a potential hurdle that anyone who has gone home and then needs to move back would have.
Right. That makes sense. And do you know, in situations like these, does the center, are they able to provide housing on short notice? Do you know how that would?
No, we don't provide housing. We have some resources, but it's limited.
Okay, got it. Yeah, I think you said what was it? The leukemia.
Leukemia and Lymphoma Society has a housing program. Now, on short notice like that for a complication, I'm not sure that would be as useful as a planned transplant.
I see. Okay, sounds good. And then in short, in general, if you can just give it a quick overview here, would a patient living locally to the center versus a patient living remote from the center experience any differences in their path of care from start to finish, assuming they're the same patient? They just live in different areas.
Yeah. In practice, after day 100, a patient who is not local will be transitioned back to their referring oncologist quicker. And will probably have fewer visits, though not no visits, between day 100 and day 360. Before day 100, there will be no difference in requirements, number of visits, or location of those visits.
Okay. And so now we've considered 3 patient types, A, B, and C. Are there any other patient profiles that might experience a different path of care?
Well, I mean, you've kind of gone into that initial diagnosis, but, the grade 1, grade 2 GVHD patient who has progressed on corticosteroids is a common patient we see, or who starts with skin-only GVHD and has new organ system involvement. Location of care may not be dramatically different than what we've just talked about, but I think addition of treatment, timing of addition of treatment might be a little more nuanced, especially when we talk about multimodal or having multiple different agents on board.
Mm-hmm.
So I think the timing of decisions on initiating various therapies might be patient specific in that situation.
Right. There's one patient type that I've thought of. If the patient, these are the two, B and C have developed acute GVHD after discharge. If patient D, let's say, gets acute GVHD while, post-transplant, while they're still inpatient, does that change anything?
Say the last part of that again?
Yeah, I just said, if patient D, for example, same profiles, but gets acute GVHD while they're still in the hospital, recovering from within the 28 days, basically. Does that change anything?
Yeah, I mean, in practice, it's a little less common. Okay. So, most graft versus host will happen between day 30 and day 100 for acute. It's not unheard of to develop that early. Anyone who develops graft versus host in the hospital before discharge after the transplant will have an extended stay. Mm-hmm. So we wouldn't discharge somebody with new, let's say he has grade 1 graft versus host that we wouldn't necessarily admit for. We would probably still keep that patient if it was new 2 days after a planned discharge. That makes sense? And does that answer your question? Yeah.
So, going back to this, are there any scenarios that might complicate the use of Product X, given that the product is initiated inpatient and is potentially completed after discharge?
No. Did you mention the duration of the infusion? Did you say it was a 1 hour infusion, or did I imagine that?
No, I did. It's just a 1 hour infusion.
Nope. There are several other medicines that we do.
Okay.
That kind of thing with, and yeah.
Okay, perfect. And if the patient is receiving Product X via home care, are there any other therapeutics that the patient might be receiving that would complicate the usage of Product X?
The most common infusional thing that patient would be on is red blood cell and platelet transfusions. But all of these patients are going to have IV access sufficient for that. So I don't anticipate that would cause many issues.
Okay, great. And for this last section, we're going to just discuss COVID-19's impact, if any. So yes, please consider any impacts COVID-19 may have brought on your treatment center or treatment of your HSCT patients throughout their path of care, from pre-transplant prophylaxis, transplant, post-transplant prophylaxis, and monitoring to treatment of acute GVHD grades 2 to 4.
All right. And can you hear me all right still?
I can.
Great. So, we have tried to only have patients in clinic when necessary, and that has led us to prefer oral agents when possible. That doesn't necessarily impact what we would perceive as the best treatment for GVHD. But for instance, usually we'll transfuse red blood cells for under 7, but if a patient feels really good and has okay energy, we might let their hemoglobin drop to 6.8, and if they feel okay, we might not bring them in for a special transfusion. Mm-hmm. So, kind of at the fringes of our decision making, it's been trying to have a little less time in a crowded hospital or infusion clinic setting.
Okay, great. And are these changes, do you see them being permanent changes or temporary?
No, we're already backing off on them.
Okay. Great.